All right. Good afternoon, everyone, and thank you for joining the 2022 North Country Leadership Summit, Optimizing Healthcare, Community Collaboration, and Workforce Resiliency. My name is Nancy Del Mastro. I'm the Telehealth Project Manager at Adirondack Health Institute. Before getting started, we want to give a quick shout out to all of our event sponsors. Thank you all for your continued support, and without that support, we wouldn't be able to host such a great event. So thank you to everyone who supported us this year and over the years. Quick housekeeping items before turning it over to our presenters. Please place any questions or comments about the presentation into the chat box, and we will address those after the presentation during a Q&A portion. We ask that all attendees remain muted with their videos off for the duration of the presentation to reduce any distractions. And as a reminder, all presentations are being recorded and they will be archived on our North Country Leadership Summit webpage, and we'll send you all an email when those are available for review. And with that, I would like to introduce our two presenters for this presentation, Joanna Loomis of Fort Drum Regional Health Planning Organization and North Country Initiative, and Pat Fontana of Fort Drum Regional Health Planning Organization.
Hi, good afternoon.
You should be able to go and share now, Pat.
Okay, great. So, hi everyone. Thank you for giving us the opportunity to present this. Let's see. Hopefully, everyone can see our screen.
Yes.
Oh, great. Joanna, I'll let you start us off.
Perfect. Well, as Pat said, thank you all so much for giving us the opportunity to speak today. This is a really exciting group of projects that we've been working on at Fort Drum Regional Health Planning Organization. We're excited to share some of what we learned and hope that it might apply and help you in your organizations as well. Next slide. So just a little bit about who we are. I'm Joanna Loomis. I'm the Deputy Director here at North Country Initiative and also work with Fort Drum Regional Health Planning Organization. And our team works in value-based contract initiatives and healthcare transformation in our Jefferson, Lewis, and St. Lawrence County region. And Pat, I'll let you introduce yourself.
Hi, I'm Pat Fontana. I work in several departments. One of them is workforce, another one's population health, and behavioral health is the third program that we work in to help mitigate problems and figure out strategies to fill healthcare gaps.
Thanks. And just a little bit about us as an organization for those of you who aren't aware. So Fort Drum Regional Health Planning Organization was founded in 2005 to connect Fort Drum soldiers and their dependents to healthcare in the region. So Fort Drum is a U.S. Army installation, and it's fairly unique in that it's the only division-sized installation in the U.S. that does not have its own inpatient hospital on base. And so that was really the impetus for our creation in 2005, was to make sure that our civilian healthcare infrastructure could really adequately meet the needs of the many thousands of soldiers, their dependents, with healthcare in the region. And they utilize our regional healthcare infrastructure, not just for inpatient care, but for specialty and primary and other types of care as well. So over the years, we've grown and evolved, and we're still, the Fort Drum is close to our heart, and we still are very active with that, but we've sort of grown into a larger population health organization that focuses on care for everyone in the region, civilians and soldiers alike. So we are a rural health network, a former FIP or population health improvement program for our region, and we have 5 main priority areas that you can see here on the screen. And so really those priorities led to the development of the 2 projects that we'll talk about today. And Pat will introduce sort of the objectives of these 2 projects in the next slide.
Okay. Thanks, Joanna. So as you can see here, what we're going to review today are really 2 main projects that Joanna and I have been working on along with our teams. along with an annual project that we've been doing since, I believe, 2016. So what we're going to review today are 3 research projects, each with slight nuances in their approach and target areas, but overall it's very similar in their objectives, which really is to identify healthcare issues and challenges in the 3-county region. And that includes Jefferson, Lewis, and St. Lawrence counties. So specifically, these issues that we're going to be discussing today are related to patient engagement and access to care. So the data and information resulting from these research projects are intended to inform healthcare related partners, basically, so they're able to develop data informed plans and then implement data driven strategies and interventions. As you can see, one project, Project 1, as we call it for the presentation, is geared towards healthcare for rural residents. And the research we did was a series of focus group and key informant interviews. And Joanna is going to talk to you about what the difference is between qualitative and quantitative methods shortly. And then Project 2, and again, their projects are very similar, but there are different nuances. So Project 2 is strictly primary care and strictly for vulnerable populations, where Project 1 was targeting all residents in the rural designated areas of our region. And it was all healthcare related issues and challenges. So again, overarching, it's basically let's identify issues and challenges, but there are different nuances to each project. And then we also added our annual project, which is the Regional Community Health Survey, to this presentation, because this is something we do on an annual basis. And this is the quantitative data that we and our partners use from year to year in order to identify those challenges as well.
Thanks, Pat. And some of you are very well versed in research method types. So we just wanted to give just a sort of brief overview for the benefit of any that might want or need the refresher. But, you know, generally speaking, research methods fall into 2 buckets, right? So there's quantitative research and qualitative research. And so part of what we hope to do with this presentation is to sort of do 2 things, right? One is show our experience of doing a mixture of both quantitative and qualitative research, which maybe you could apply to completely unrelated projects that you might be working on. The other thing is to talk about the actual content of our research projects, which again, as Pat noted, relates to healthcare access and experiences, which also may relate to your populations and your counties in which you work. So back to the research methods, again, quantitative is really around measurable responses, focusing on what, when, where. It's fairly structured and can be trended over time. Quantitative research can include things like surveying and other research methods. And one kind of benefit of a quantitative type is that if you get a big enough sample, you can statistically say that it has a fairly low margin of error, and you can actually statistically kind of indicate with confidence that the feedback that you gathered from the populations you just researched is representative of larger populations within a region. And that's not necessarily so much the case with qualitative research, where you really can't, if you have 10 people in a focus group and all 10 of them feel a certain way about something, you really can't then, state that that is representative of the entire population, a similar population in the region. But what you do get out of qualitative data is more texture, more emotion. You can get things about why people feel the way they do. You can sort of start to understand a little bit more about their perceptions of things. And it is more descriptive, more contextual. And qualitative research includes things like key informant interviews, where you're kind of having a one-on-one structured interview with someone in the community that is considered an expert or a subject matter expert in the content you're working with. And it can also include things like focus groups, where you are bringing together a group, 4, 5, 10 people that, sort of were screened into the process, and you have a very structured set of questions and flow for what you're asking them. So, you can see here on the slide, there's sort of a very simple 2 examples of related but different questions that you might ask in a quantitative versus a qualitative research method type. Quantitative being, how long has it been since you last had a primary care visit, right? Very straightforward, measurable. And qualitative might be something like, tell me more about your experience with your last primary care visit.
Yep. And so simply put, quantitative data gets you really the numbers to prove the, what do you call it, the broad general points of your research, where qualitative data brings you the details and that depth to understand that the full implications of the quantitative data that you did get. So they're very complementary. And now we're going to discuss the annual community health survey. So one of our population health projects each year is to conduct a community health survey. And that's in the 3 counties of Jefferson, Lewis, and St. Lawrence. We do this in part to help our local hospitals and public health agencies who need data in order to provide New York State with a health assessment and a health improvement plan on a regular cycle. So since they don't have the resources to conduct annual surveys, we help them out by providing this service for them. So our service really, it provides probably the most timely data that they could get. And that's data that also aligns with their priorities, because we partner with them to make sure that whatever their priorities are, that's the type of data, and that's the data that we're trying to acquire for them. So the survey questionnaires that we develop is developed collaboratively with them and all the healthcare agencies to ensure that the collected data has some meaningfulness to them. And as to the nature of the study itself, so the survey development, there's a sampling methodology that we use. An analysis is completed by statisticians and data analysts. They've had decades and decades of experience doing this type of thing. And so they generally would suggest that we use what's called a multimodal randomized sampling procedure. And that really helps to ensure an adequate representation of the regional population demographics. Otherwise, because if you look on the screen here, this year, which 1976 surveys is what we conducted in the 3 counties. And that's actually a pretty good number. That was very good engagement for 2022. We're really pleased with that. But for those of you that are doing the math going, all right, wait a minute, Jefferson County's got what, 110, 115,000 people. St. Lawrence County has around the same. And then Lewis County has 26. We're talking 240,000, and you only got 2,000 survey responses. How does that even, well, the math behind it does show that 2,000 surveys in a population of 240, 250,000 can have a margin of error as small as 2.3% for the region. And that's exactly what we did accomplish this year. So while the sample size seems small compared to the population of the region, the mathematics that underlies that analysis indicates that our regional estimates are very accurate, and that accuracy is within 2.3% average of the margin of error. So sample size of around 2,000, we were very happy with, and we're very pleased with the engagement of the North Country residents this year. The results were weighted towards population demographics, which means that out of all the folks we surveyed, if a certain percentage didn't align with the percentage that is actual for the population, then it was weighted to make sure that it does. So certain demographics and certain target populations were weighted to align with the actual percentages of the population. I know I'm getting too geeky here, so I'm going to stop. But that's essentially the methodology behind our annual community health survey. And I'll have Joanna give you some details of that survey.
Sure, thank you. And definitely don't have the time to go through, of course, the entire survey. We do have it available. If anyone is interested, feel free to reach out to Pat or myself afterwards. But it's a very detailed report with lots of analysis. We asked, dozens of questions of survey respondents. But we thought we'd pull out just a few kind of data points that were most relevant to today's presentation. So one of the things that we talked with respondents about was primary care. And so you can see here that roughly 8/10 of people surveyed did indicate they have someone that they think of as their personal provider. And then of those who answered yes to that question, we asked, what kind of provider is that? And again, roughly 9/10 of those indicated that that was a true sort of primary care provider, with the other 9% choosing things like urgent care or a specialist of some kind. So again, the point there was trying to see, are there a number of people in the region that believe they do have primary care, but it might actually be, say, provided by a cardiologist, for instance, or they may think that an urgent care is their primary care. So just getting a little bit at that, we did see the overwhelming majority indicate that it is sort of quote unquote true primary care. And then again, back to all participants, we asked them how many of you have had a primary care service in the last year, and roughly 3/4 indicated that they did. So that's great. It does indicate, of course, that 1 out of 4 people surveyed did not have a primary care visit in the last year. We also asked them about access and challenges receiving different types of care. So again, on this slide, you can see about 1/4, or 1 in 4 people, said they did have difficulties receiving primary care, which fits in perfectly with the previous slide and the finding that 3 out of 4 have had a visit in the last year. And you can also see that there's a fair amount of difficulty among residents of the region in receiving dental or oral health services. That's sort of the front runner. And I would note that people could choose more than one response for this question. So you certainly may have had someone who answered yes to multiple or even all of these. So just giving you a sort of glimpse, and I think it's important to note too that obviously some of these types of services arguably apply to everyone, right? So arguably everyone should be receiving some type of dental, primary care, even eye care services. So the sort of the way the graph tapers off near at the end with behavioral health, women's health, pediatric, and substance use, a little misleading just in that, obviously you could think of it as a greater portion of the people that for whom those types of services actually applies to them, received challenges in experiencing and receiving these services. Next slide, we can see that when you can do some demographic sort of sub-analysis of the types of respondents who answer certain questions, you can see that there's some populations of greater need. And we've found that people who had reported less than good dental health, they had a higher difficulty accessing, a higher percentage of them had difficulty accessing dental or oral health services. And you can see that trend sort of apply to the other services here on the screen, with less than good physical health corresponding with, potentially greater difficulty accessing primary care, less than good mental health corresponding with behavioral and mental health service challenges, and similarly with pediatrics and children. And next slide. So what were the barriers that were cited? So for this question, we actually made respondents pick only one. They could only pick one single largest challenge in receiving healthcare services locally. And so you can see that the largest by far was long wait time, generally thought of as that they faced a long time between trying to make the appointment and when their appointment would actually occur. And that's related to a few others on here. You can see no available providers, similar sort of access issue potentially there. So long wait time was followed by cost of care and poor experience with provider and difficulties with their work schedule. And you can see how the others pan out on the screen as well. And I think, again, important to note that, of course, the people responding to this question, some of them probably face multiple barriers to care, of course, but we did ask them to really identify the most significant one for them, which I think was useful. And we really see that long wait time rose to the surface as sort of the front runner there. And I would also note that what you just saw in our kind of quantitative analysis absolutely lends in very well with what we're going to present with the two more qualitative research projects that we've done in the region. And you'll see that there's a good deal of synergy and alignment there. So with that, I will turn it over to Pat to discuss his team's qualitative project.
Thanks, Joanna. Yeah, and she's absolutely right. The alignment is, unfortunately, the alignment is there. And it's fortunate that the data that we've acquired aligns with one another, because that's what we want to happen. But it's unfortunate that the results are what they are in terms of the long wait times, and the long wait times are generally related to lack of services, provider shortages and things like that. So the first qualitative research project that we're going to talk about is called the HRSA Rural Northern Border Regional Planning Project. And right before we started this presentation, the six of us that were meeting to test out WebEx here, we were talking about acronyms, and there's an acronym for you. It's probably one of the biggest acronyms I've seen. So the Rural Northern Border Regional Planning Project it's a little bit different than projects that we've worked on in the past. This comes from, and it stems from, stakeholders that belong to 4 states: New York, Vermont, New Hampshire, and Maine. And they got together to form a partnership. They also formed a partnership at a federal level. So that's why they call it a federal state partnership. And they partnered with HRSA, who generally funds their programs. And the purpose of their formation was to enhance the development of economics, community development, healthcare development in the rural designated areas of this region that we're talking about, that you see in blue here. And part of the way to do that would be to conduct community health needs assessments, to do research projects and things like that. That's where we come in. So you can see in New York, all of the counties that either are considered rural or are considered to have portions of it with rural census tracts in them. So if you look, I know it's probably tough to see, but if you look at Lewis, it doesn't have a superscript there, or an exponent, whatever you're going to call it. And if you look at St. Lawrence, that does not have one at all, but Jefferson does. And those are our 3 counties. So the superscript above Jefferson is an indicator that Jefferson is not completely designated as rural, but there are rural census tracts within Jefferson. And so we had to be very careful on where we did our research, because HRSA is Health Resources and Services Administration, designated just for rural communities. So for this particular project, the purpose was to identify and assess key rural health issues and challenges in only the rural designated areas of the region, to help healthcare stakeholders address disparities in underserved communities. Now, the target population was good in some ways, and in other ways it was tough, because sometimes the broader you get with a research project, the more difficult it is to hone in on those challenges. And there were 2 broad areas of this. One was our target population. Yes, they were all rural, but it was everyone within the rural area. So it's everyone in St. Lawrence, everyone in Lewis, and everyone within the rural designated areas of Jefferson. So not a specific demographic within those areas. And the other part that was very broad was the fact that we were trying to identify healthcare issues and challenges, period, not in a certain area, not in primary care, but just overarching issues and challenges. And so in some ways it made it easier, but in other ways, when it came to the analysis, it did get a little bit difficult to pull out some of those details that we need to come up with, data-driven decisions. So the methods we used were obviously qualitative and quantitative that we talked about before. The project timeline, we're in it right now. And the focus of the work was for planning purposes only. And they stressed that a lot. They said, this is only for planning. This is not to implement anything. It is to plan, to prepare to implement. So this was basically to inform our partners and to inform us for planning purposes only. As you can see here, the grayed out areas are the areas that we had to focus on. St. Lawrence entirely, Lewis entirely, and then only the rural census tracts in Jefferson County. And that got a little tricky too, because there are some counties, some towns that part of them are rural, part of them are not. So are we asking this person that? So we did the best we could to keep everything exactly the way that we're supposed to and keep everything designated as rural. The qualitative research we conducted were key informant interviews and focus groups. We had 13 key informants, and key informants are subject matter experts that have a specific, unique, extensive knowledge about the community from a certain perspective. So a lot of times they're professionals that work in the healthcare field. Sometimes they can even be, in our case here, would be school officials or people that work in school that deal with youth who have healthcare related issues, things like that. So we had in-depth discussions with them in order to figure out what their perceptions, their ideas, and their opinions on our basically the state of the healthcare system for the folks that they serve. And then we wanted the other end of the spectrum. We wanted residents. So we went and did focus group, and these were community residents. They weren't necessarily subject matter experts, but they were experts in their own healthcare. So that we got from, basically right from the sources, what their issues and challenges were. And we had 8 focus group discussions with residents and came up with, I don't think any of the information is going to be mind-blowing to you. A lot of this will probably be expected. I don't think there are any surprises here, but it does confirm some of the things that we've been hearing and seeing. So in terms of the key informants, far and away, the biggest challenge that they discussed with us were the provider shortages. And we asked them, well, in what areas? And almost every single one of them said, oh, all areas. I said, well, yeah, but specifically what areas? All of them. And that's the response we kept getting. So we tried to dig a little bit deeper, and they said, well, all of them, but if you had to make me choose, dental's probably a little worse than this, pediatrics a little worse, mental health. So what we did here for you was to give you an idea of some of the worst shortage areas, which were dental, specialty services, pediatric, mental health, youth mental health, and disabilities. Those were some of the areas that folks are struggling in right now. And obviously the resulting issues, and again, this is no surprise, would be transportation issues, wait times, and high turnover rates. And I know you're going to look at the slide here and go, you've got transportation in there 1,000 different times. How come? We did that purposefully because transportation it's a strange one, because if you're talking about transportation for folks that are rural, that could be slightly different than transportation for folks that don't have a car or don't have public transportation, or they are in poverty. So somebody could be very, very well off living in a deep rural area and has to utilize specialty services once a week or once every 2 weeks, and has an issue traveling to Rochester. So that's a transportation issue, but it's not necessarily a transportation issue that's related to not having a vehicle or not having public transportation. So we put transportation in the areas that we thought we needed to put it in. So it's not just in there one time. So provider shortages was far and away the biggest challenge that there were. And then the other issues revolved around what we would call socioeconomic, sociocultural issues, poverty being one big one. And again, poverty, what are some of the results there? Lack of broadband. Some insurance is not being accepted by providers or just being uninsured. Obviously, transportation. There were some health literacy concerns from key informants of a lack of awareness in the community, but also the inability for people, even if they had an awareness, to advocate for themselves and even to know where to find a provider. Because if you think about it, we no longer, my grandmother used to flip the phone book open and find a doctor in the yellow pages. That doesn't happen anymore. I don't know if anybody gets the yellow pages. Maybe they still do, but I don't get them. So I'm assuming that that's not that same type of way that we're trying to find providers in the area. Some people have a hard time even knowing where to go to find a provider. And then obviously the overarching rurality of the areas that folks live in cause a lack of broadband, again, transportation, and just that lack of services and resources. So, you're looking at this and it's very tough to try to segment the issues here because they're all intertwined. So that's why you're going to see some that look a little bit redundant. And then I'll just let you read some of the key informant quotes here. These were some of the quotes, direct quotes from key informants. The one that stands out to me from a provider's perspective was that, so transportation is a big one in the office. On the adult side, we have a 30% no-show rate. That was shocking. So I said there's no surprises. Well, there's one surprise, at least it was to us. That was a big surprise for us, a 30% no-show rate. And they attributed that for the most part to transportation issues. And then the bottom one there from key informants was provider turnover is because of climate, culture, and better opportunities. So I'll move on to focus groups. So again, focus groups were residents of the rural communities that we went out and had a fairly long and meaningful conversation with. And again, far and away, the biggest challenges, according to them, were wait times are too long. And again, it's wait times in order to even get into a provider to be seen. That's why I put the word months after there, just to have that indicator. Of course, I'm sure if you're waiting in the waiting room, it sometimes feels like months, but sometimes there's a confusion over, is it wait times within the waiting room or is it wait time to even get to be seen? It's generally wait times to even be seen by a provider, getting established by a provider, lack of specialty services, pediatric services, mental health services, which aligns very, very well with what the key informant says, which also aligns with what our community health survey is indicating as well. Again, the socio-cultural factors was the inability to find services, childcare issues, transportation issues, a lack of broadband, affordability, lack of awareness, unable to take time off of work. There were a few that said, I don't go to a provider unless I'm on my deathbed, unless I'm very sick. So there's that it's a cultural, tough guy type of mentality there. So we put that in cultural, socio-cultural. There were some positive experiences too that I think are definitely worth mentioning. One being telemedicine. For those with access, now not everybody did. So there was a complaint that sometimes they can't get it, but for those with access, it has overall been a positive experience. Primary care encounters, we had more than a couple mention that if they are established, then it's fairly easy to get seen by their primary care provider. And then several also mentioned that they've had overall good experiences with a provider. Not all, but it's worth noting that there were quite a few that did. And then some also mentioned that patient portal convenience was something that they hope continues as well. And then you can also see the negative experiences over to the right. I love that one. Still have to wear a mask. That was not just one person. There was a couple of people that said, I don't like going because I don't want to wear a mask. But service times are inconvenient. Insurance not accepted. There's a lack of trust in providers, feelings of being judged or feeling like they're not being listened to or they're feeling rushed. We heard that on multiple occasions as well. So those were our focus group and key informant, our findings for that. And here are some of the quotes from from the focus groups that I'll let you take a look at. You notice the third and fourth one, this is what stood out to us, I think, the most, where it says, I don't want to run into somebody that I know on my way to the wellness center or have somebody see me coming out of the clinic. That one was very, very telling. That points to maybe there's a level of stigma attached to whatever that service is that they were accessing. And then the other one below there, I know I should have gotten treated a long time ago, but I didn't think I had support from work or my family. And that was another quote that we thought was very, very telling as well. And so in short, in summary, really provider shortage far and away was the biggest challenge that we've heard from both groups. And that really had that resulted in wait times, transportation issues, taking time off work, having childcare issues, an overworked workforce, which probably helped to contribute to people feeling rushed and people feeling not listened to. And then also the socio-cultural factors that we discussed as well, just from the sheer fact, for the most part, of being in a rural area. So it's that rurality that, while there's a lot of benefits to living in a rural area, there are some challenges as well. And we certainly did hear that from the folks that we had these discussions with. So that's it for my project. I just wanted to make sure that that even though we said this is for planning purposes only, and that is true as far as the grant project that we're working on, obviously this work has to go toward meaningful action. And that's exactly what we intend to do with it. So what can we do? What can our partners do? And what what things are just areas that we can't do anything about? So I kind of try to place them in 3 buckets to show you. There's some that we maybe can help with, maybe raising awareness, maybe providing some health literacy, cultural competency training or awareness, transportation support of some kind, trainings, pipeline programs. And then some that we can help our partners with, or our partners can address them when it comes to telemedicine, insurance, and affordability. But then there are some that maybe we can advocate for, but directly they may be somewhat out of our control, that we either can't do anything about, or we can maybe at the very least let folks that can control these or help with these know what we found. And so that's it. Joanna, I'll let you move on to your project.
Sure, thank you. So Pat and I have talked about our projects as being sort of a Venn diagram of sorts, and there's ways in which they overlap, but there's definitely a few differences as well. So if you go to the next slide, you'll see just a little bit different in kind of our timeline, our population. If you keep advancing, perfect. Yes. And then you'll see that our timeline is actually this calendar year. So we're still in the middle of our project, and we're wrapping up getting the focus group interviews done. And now we're kind of moving into the dissemination and report phase, and really kind of working with our partners on what do we do next, which we'll get into near the end. But our population was really intended to be people who had Medicaid or Medicare as insurances, or who were uninsured, hence the quote unquote sort of vulnerable populations. And we were looking to speak with people who hadn't had primary care visit in the last 12 months. Although I will say that we did end up speaking with some who had recently engaged in primary care, and their insights were really just as valuable because they could speak about primary care experiences. So for some background, I think probably most of you watching know this and kind of live and breathe this, but significant evidence links primary care engagement with positive health outcomes. We can see that there's better birth outcomes, lower rates of vaccine preventable illness, increased early detection of treatable disease, reduced effects of chronic disease, and prolonged lifespan associated with primary care engagement. But as you can see, in the US overall, a lesser percentage of healthcare spend in our country is primary care related compared to sort of other quote unquote developed or OECD countries. And in our region, you saw that about 25% of our residents reported not having had a primary care visit in the last 12 months. And that aligns perfectly with the data that we receive through claims data from payers for value-based contracts that we help manage as well. When you look at the target population for this group, so again, those Medicaid, Medicare, or uninsured individuals, that figure rises significantly to about 35% of those individuals not having had primary care visit in the last 12 months. So we really set out on this project because we wanted to know more about why and uncover some of those reasons through both quantitative and qualitative methods. And we really deliberately incorporated focus groups because we wanted to incorporate feedback from the target population themselves. They are subject matter experts in why they are not getting primary care, at least to some extent, right? So, and it also aligns with, evidence-based practices that really encourage, you to seek out information from your target population when you're making decisions about them or for them or coming to conclusions about them as well. So next slide. So again, we incorporated pieces of the survey, the community health survey that Pat and I discussed earlier, and we conducted focus groups and then what sort of turned into sometimes just key informant one-on-one interviews. So our vision was that we were going to have 8 focus groups of 8 participants each. It was going to be beautiful. There was going to be rainbows. In reality, that is not what happened, and that's okay. So we really kind of went gung-ho. We created flyers. We promoted these through social media, through our partners, and we had a whole bunch of people sign up, and the vast majority of them ended up being sort of fraudulent. They were people that were interested in the gift card associated with it, and so we had to kind of sort through that. And of the remaining 28 people that signed up, only 13 were able to be reached and actually signed up for the focus group. And then of all of the people we signed up, only about 40% actually attended. And this was despite numerous reminder calls and emails and the days and the hours and the minutes leading up to the scheduled focus groups. And I think it's important to note that in and of itself is a significant finding because there's some parallel processes in play with signing up for and attending a focus group and signing up for and attending a primary care appointment. So we can certainly tell our partners, we felt a little piece of your pain when you tell us that, certain populations are really tough to get into the office for visits. We certainly experienced that with this. And this was arguably even easier sort of to engage them theoretically because we were doing virtual groups, we could do phone calls, we had the $50 gift cards. So bottom line, what we did was we had to change our approach midstream and we had to truly meet the population where they were at. So we shifted to doing some hotspot locations. We went to several soup kitchen, we went to a mental health association where people sort of spend parts of their day, and we met them literally, physically where they were at. And then for those that we were able to engage through a phone call, our team actually offered to do the interview right then and there instead of having them call in at a separate date and time so that we could just capture them right when we had them on the phone. And those approaches worked wonders for this project. So what did we find? Again, this header isn't shocking. There are barriers to primary care access, and a lot of those barriers relate to what Pat shared in his project as well. This notion of inconvenience, that the structure, the wait time, the location, the lack of same-day appointments, that those were significant barriers to access. Transportation was a huge one, and several people told us kind of stories of how they secured Medicaid transportation, you know, where someone comes and picks you up and takes you to your appointment. But there's times at which that person never shows or they're late. And then you, as a result, as the patient, do not get to your appointment on time. And if that happens multiple times, then some providers might, quote unquote, fire you as a patient for noncompliance. So then they had to start all over with a new office, which was a huge barrier. And I won't get in too much to this, but for any of you on the call that have been trained in Bridges Out of Poverty, there's a couple notions here that aligned very well with what we heard from participants, which is this notion of tyranny of the moment, that for potentially impoverished participants, if you're spending 95% of your mental and emotional energy every day kind of on basic survival needs like housing, avoiding eviction, moving into a new place, finding food to eat, basic stuff, then that's going to consume you. And this notion of preventive care is incredibly irrelevant and unimportant to you, and it overshadows vastly your desire or your motivation or your capacity to even engage in such care. Another item was something called the hidden rule of destiny, which sort of basically is, we saw this come up in multiple comments where you feel fated, and as a result feel sort of powerless to take charge of your own health. So this would come up if someone said, you know, I really haven't engaged in dental care because my family's teeth, they all fell out, mine are too, why should I even bother? Or, you know, everyone in my family has diabetes, I'm definitely just going to get diabetes. Like, what am I going to do to prevent that from happening? So next slide, you can see some quotes that capture a little bit of this. There's definitely a number of people who are employed and may have Medicaid or Medicare, or who are uninsured. And these people cited often having maybe retail, food service jobs that were not conducive to just popping out for a primary care visit. Medicaid, lack of Medicaid acceptance was huge. It came up time and time again that finding anyone who accepted Medicaid was really tough. And then the transportation, and then the bottom one here very much relates to that tyranny of the moment. Next slide, looking at negative healthcare experiences. So for those who did have primary care engagement in the very recent or even not so recent past, there's some themes here around the customer service of the practice and their emotional intelligence, feeling like they weren't heard or respected, you know, that the structure itself was just not very friendly to themselves as customers of the practice. And, you know, you hear echoes of what some of Pat's team found in their project as well here. A concern about infrastructure, again, just not being adequate. There's not enough appointments, huge lack of coordination in some cases between their primary care and their specialty care. Paperwork was a huge one. We had multiple people indicate that the paperwork was so overwhelming, so intimidating, especially for those who did indicate that they have health, well, overall literacy issues, that they were actually so embarrassed they literally did not go back. It was too much for them. And then this feeling of, again, I think it was a quote directly from Pat's project, you know, I feel like I just start to get to know a provider and then they're gone. We heard a lot of that with the people we spoke with as well as some significant insurance roadblocks that I think probably we all can relate to, but definitely were overwhelming for this population that, again, you're living in that moment. You don't have a lot of time to be able to be on the phone for hours trying to get information from your insurance company. So next slide. And I think that second quote is deceptively small. And I would argue that's huge, right? That if your patient does not understand what what you as a provider or care team are conveying, then that patient arguably probably it made no difference to them that they even had the visit that day, right? So it might have even hurt their health if they feel frustrated that they don't really understand what's being talked about with them. So certainly plays into health literacy. Next slide. We did find some very positive things though too. So these were things that showed to us, again, gets at perception. When primary care is really working very well in our region, what does it look like? And it looks like competent care, emotionally intelligent care, feeling like the provider has a relationship with them as a patient, feeling available, accessible. And here was another thing that we thought was very interesting, that numerous participants talked about. We need to get more quote unquote mid-levels or nurse practitioners, physician assistants, because they perceived that those provider types had more time to spend with them than the people who had an MD or a DO behind their name. Very interesting, and we asked them for solutions. You'll see this in a few slides. But that was one of their solutions, is can we get more NPs and PAs in our area? Because some comments also referred to those individuals as being maybe more perceived as more local, that they sort of grew up here and they're kind of more likely to spend more time here. So that turnover that people experienced with MDs and DOs was less visible with these quote unquote mid-level providers, which is very interesting. Next slide. A few more questions that really conveyed kind of some great things that were happening in the region around primary care. And then finally, what are some solutions that they themselves would suggest? And I have to say it was hard condensing this to one slide. There's really so much more than this, but we tried to pick out some of the kind of key themes. But again, you see more mid-levels. There were some really great suggestions around telehealth, house calls, health advocates was a huge one that also synergizes very well with Pat's findings too. There was definitely a feeling that they felt so much more confident when they had a trusted family member, a friend, a trusted case manager or care manager in the room with them to help them ask the right questions, help them translate and understand what just happened in that visit. Some, support with paperwork and referrals, and then a change in workflow too. So instead of just sort of maybe asking, do you have any questions? Change that to, what questions do you have? More inviting a person to speak. And then there were a number of comments around feeling empathy for healthcare staff and feeling like maybe we could better support them with trainings that help them be more health equity minded, health literacy minded, culturally competent through certain trainings that promote these things. And yep, a few more quotes. And I like all of these. Again, there was thousands of quotes we sorted through, but this last one I thought was really interesting. And that leads very well into the next slide, which we would say is sort of an Uber finding. If at this point, if we had to sort of boil it down into one sentence, I would boil it down into this first sentence, which it is as much, if not more, about how your care team relates with patients as it is about any clinical decisions that you make. We can't stress that enough, that was an overwhelming theme from these focus groups that we did. And we also would note that, there was some frustration with the structure of primary care in our region. And we've heard from the provider side a similar frustration with particularly the Medicaid population and their really high no-show rates. And so there's a disconnect there, and it's probably frustrating for everyone. So what can we do to adapt? What can we do to change that? So that brings us to the next steps. which for this particular project is that we are able to provide a Bridges to Health and Healthcare training, which is sort of based within the Bridges Out of Poverty kind of body of work. We'll be doing that for our primary care partners next month. We will also present a version of these project findings that you've just seen today and have a discussion. You know, what can be done? Are there win-wins out of this? And I'm convinced that there are some win-wins that would decrease no-show rates among these populations, and that would make our partners happy, and get more people in and get them the care that they really need. So we'll also be completing a much kind of more comprehensive final report. So look forward to sharing that with you know, anyone in this group when that time comes, because as I said, we had to, obviously for the purposes of this presentation, condense things down quite a bit and just try to bring you the key points, but there's so much there that we didn't get to cover today. And that's it for our team's project.
Well, thanks, Joanna. So I know we're running out of time, so I'll make this quick, but just in summary, you know, wait times, having to travel out of the county or the region, difficulty navigating the healthcare landscape, finding providers, whether it's because of lack of technology awareness or whether it's just a shortage of providers, not feeling listened to or respected, feeling rushed, and then your sociocultural issues when it comes to you know, insurance affordability, transportation issues. So these were a lot of the things that we found in all three, really in all three research projects, both qualitative and quantitative. And really this data and this information will be used to improve these issues and improve these challenges in patient engagement and access to care. And also it helps to inform and support our network partners in a, you know, a variety of things that they have to do, which is strategic planning, making data-informed decisions for those plans, any required reporting that they have, really just to track progress. And often it's also used for funding opportunities, often to show need in the area. So that's really it for our three project reports. And I don't know if anyone has any questions, but we're happy to answer anything you have.
And I did see Bob put in a question. He asked, did respondents complain that primary care providers charge for an office visit for no-shows as impacting their decision to even schedule an appointment? I would say for our respondents, I don't believe any of them specifically spoke to that, but there was definitely very much a recognition that if they do no-show, that they risk basically being, again, discharged or fired from the practice for non-compliance. So sort of related. Pat, I don't know if you had any specifically that spoke to that.
We really didn't. We didn't focus a whole lot on specifically primary care, and it didn't come up in conversation with any of the folks we talked about. Again, affordability and lack of insurance did, so that's somewhat related, but not that specific question. No.
And then I think Stacy asked, is this presentation available to share? And AHI team, tell me if I'm wrong, but yes, I believe it will. I think these are all being recorded and our slides will also be shared after the summit.
Yes, that is correct. Thank you, Joanna. And if there are any other last minute questions, Joanna and Pat, if you wouldn't mind just placing your emails in the chat.
Absolutely.
Just because we are getting we're about a minute out now from the end of the session, but if there are any follow-ups, feel free to reach out to either myself or Joanna and Pat, and we'll make sure that any questions you have are addressed. And before we hang up for the next session, I do want to thank both Joanna and Pat for joining. This was really fascinating. I love to see all of this data, and we look forward to the next steps and seeing what's to come from this the multiple awesome work you've been doing in these programs.
Thank you, Nancy.
Thanks for having us.
Thanks so much, and we hope to see everyone at our next session at 3 p.m.
Thanks.
Have a great afternoon.
Bye, everyone.